Good afternoon. Good afternoon. I'd like to welcome you to today's Medical Center Hour. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities here in the medical school, and we're delighted to welcome all of you here on what feels like, I hope, one of the last summer afternoons, right before the start of fall. What still resonates with you when you're spent? Physically, emotionally, morally, spiritually spent. If you're a caregiver or a teacher, a leader, a colleague, someone on the front line in another of the serving professions, how do you persist and endure when you feel thoroughly drained? At such times, what can we offer and do when all else fails, when all we have left is our humanity? For all of us in Charlottesville, recent weeks have asked much of many of us, our first responders to be sure, our clinicians, our clergy, our public servants, our teachers, our students, and others. And during these same weeks in other parts of the country and across our world, natural disasters of historic proportions have burned, blown, flooded, rocked, sickened, and killed. Help on site has come from dedicated professionals who have worked superhuman schedules, confronted calamitous devastation and loss, witnessed great suffering, and then worked some more. How do they do it? And how can they do it in ways that enable them to persist and to maintain some emotional and moral resilience? What human resources might they yet have available? We welcome today Tim Cunningham to this Medical Center Hour. With preparations in both nursing and the narrative and performing arts, Tim brings an unusual sort of expertise to this forum. In this hour, he will weave together 3 stories from disparate sites and desperate situations to inquire into what might matter the most to us at the most trying times. A clown, and then a nurse, and now the director of the Compassionate Care Initiative in the School of Nursing, and an assistant professor there, but also with a joint appointment in the university's Department of Drama. Tim will share what he believes matters most when all else is lost, and he'll show us how we actually all have the capacity to access it. I will mention too, Tim has been here before, produced a one-person play that he had written and acted something like, 20-some parts, which included him standing on the furniture, which I don't think he'll do today, but I'm not sure. He also has declared no financial conflicts of interest for this program. And so now Tim Cunningham, and at the end of the hour, we'll have time for interactions with you, although he may involve you earlier, too. Thank you. Welcome, Tim.
Thank you, Marcia. I learned as a student at UVA when I was getting my CNL degree at the nursing school, a very important lesson that I'd like to share before I begin. I was doing some research in Limpopo Province, South Africa. We were working with community members trying to understand their perceptions of water, how they used water, what mattered most for them when it came to water. And we brought some community members in to speak with students at the University of Venda. And this amazing thing happened. We invited one of the elders from the community to come in, and she walked up, we introduced her, and she did this. And she was an older woman, and as a nursing student, always looking for the nearest emergency, I thought she was about to do this. And I spoke with her afterwards, and I said, what is that about? And she said, in our community, before we speak publicly, the first thing we do is we pause, and we take a moment, and in that moment, we respect the collective wisdom in the room in front of us. We respect the wisdom that each individual sitting here in the audience brings to this discussion, this discourse today, and we say to ourselves, oh my God, who am I to be talking in front of this group of people? How grateful am I? So thank you for giving me the chance to speak and share some stories. I'd also like to express gratitude to those mentors of mine who are in the room here today, people that I'm going to speak about, those living and those who no longer are living with us. I do need to start with a disclaimer. We love disclaimers here. I have no financial conflicts of interest. If I did, I probably would have retired by now. I also do want to make it clear that I am a clown, and I realize with the release of the new Stephen King It and on the coulrophobes, there might be some coulrophobes in the room. There will be no clowning today. So I just want you to know that you're all safe, you're all fine. The second disclaimer that I want to put out there is that every name that I use is a changed name. I have not gotten permission from the living and the dead who I'm going to be speaking about. So all the names that I use are pseudonyms, just to let everyone know. And the third disclaimer is that I'm not going to talk about clown. This has nothing to do with clown. And I think it has everything to do with clown. But I'll let you all decide. The first story takes place in Sierra Leone, a town called Port Loko. In January of 2015, I was working with an organization called Partners in Health. I was a frontline nurse treating Ebola patients. As a pediatric nurse by training, I spent most of my time working with pediatric nurses. And shifts were horrible. On average, we lost 2 patients a day. We had no supplies. We had a pharmacy that had about 9 medications in the whole pharmacy. And those 9 medications we had to use to treat every condition that came in. A little bit of context was that when Ebola hit Sierra Leone and other parts of West Africa, hospitals and clinics shut down. 800 plus medical providers, nurses, and physicians got sick with Ebola working in West Africa. Roughly 500 of them died from Ebola. So hospitals and clinics said, we can't run the risk of spreading this disease anymore, so they're shut down. As Ebola treatment units opened up, we had to screen every single patient that came to us to first see if they had Ebola or not. If we deemed them negative for Ebola, we had a checklist with 10 questions. If they met the criteria by saying yes to 3 of the 10, we brought them into our treatment unit. If they didn't meet criteria, we stripped them naked, took everything they brought into the treatment unit, washed them in bleach and soap and water, and sent them home. But the patients that came in who met criteria, we brought them in, we drew their blood, we sent their blood to the local lab, and it took 2 to 4 days to get lab results back. Another piece of context I want to share is that in the US, if we are suspecting Ebola, we draw your blood, and within 4 hours, we can have the results. A little more context, I was working about 3 hours outside of Freetown, Sierra Leone, and there was a clinic set up for expats there, people from other countries who came to do the work. They had a portable lab, and in their lab, they could run tests within 4 hours. But the majority of those who were sick and at risk of dying had to wait 2 to 4 days in our treatment unit. About a quarter of the patients that I worked with that died of conditions other than Ebola. We had 9 medications to treat everything. No oxygen, no insulin, no albuterol. Run the list. We had very limited supplies. So January 2015, this is a map. This is an image from a children's book that I'm working on about resiliency and about the Ebola epidemic. I want to start by telling about 3 very important people I met that night in July. Coming into triage, we had one elderly man arrive, and he looked great. We saw some patients that looked horrible. We saw some patients that arrived to us dead. This man looked amazing, and he had my father's eyes. He was my father's age, and I looked at him as he sat in a chair, and I said, here are your supplies. He had a fever, he had been at a funeral, and he had some nausea, so he met criteria to be treated in our Ebola treatment unit. I looked him in the eye, and I said, you look good. Here's some fluids. I'm going to give you an IV. We're going to hydrate you like crazy, and I want you to drink or die. Literally, you will drink or you will die, because the only cure for Ebola, the only treatment, is hydration and maintaining hydration. And he looked me in the eye and he said, yes, sir. And I walked him back to a room, and I thought, this guy, he's going to be one of our survivors. We're going to celebrate him in a couple weeks when he clears Ebola. There was that gentleman. There was a nurse we were treating. She was 22 years old, and she was horribly ill. Her blood results had gotten lost, so she was in our suspect ward for 4 days. Her results were lost in the lab. I mean, we were literally taping and handwriting patients' names on these tubes. That's all we had. Her results were lost, so we had to draw again. She was becoming encephalopathic, which means she literally lost her mind. And that usually happened with patients 2 or 3 days before they died. Her eyes sort of started to bulge out of her head. We called it the wide-eyed stare. And though we had limited diagnostics, when we saw the wide-eyed stare, we knew that the patient only had maybe hours left to live. She was a nurse. She got Ebola by treating and saving other people's lives. And she was dying alone, encephalopathic. And she was a fighter. She did not like it when I started IVs and when I gave her medications. She was always taking care of others in the room around her before she got very sick, before herself. She was a nurse. I think we can relate. So we wanted to take care of her and make sure she had a good death that night. And then the third patient that I want to speak about was a woman named Kadiatu. Kadiatu was 24 years old. She came to us 26 weeks pregnant. She was eclamptic. The ambulance that she was brought in backed into our triage. We sprayed the ambulance with bleach, which is what we normally did. We opened the ambulance, and there she was convulsing on the floor of the ambulance. We brought her out. We gave her Valium, which was the only medication we had to treat convulsions. And then we called the local hospital and said, please, 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 we will give anything for some magnesium. After hours-long discussion with the hospital down the road, we were able to get enough IM doses of magnesium that we could treat her 5 milligrams every 4 hours, at least until she died. Our goal was to keep the seizures under control. That was the beginning of my shift that day. We had 70 other patients that we were treating in the treatment unit. We had 2 nurses, we had 3 sprayers, people who would spray everything with bleach, and we had a couple other technicians who would help us move patients. Went into work, said, this is what we're going to do. These are the 3 people that I'm really thinking about, I want to prioritize. And then the power went out. Everything shut down. We had a rule at our Ebola treatment center that if there's no electricity, you do not go into the treatment center because it is so dangerous. You'll trip, there were exposed nails, there were a lot of hazards. And so I spent the whole night shift standing outside of the fence listening to people actively die because we could not go in. Why did we not have power that night? Because a community member needed gasoline to fuel their car or their generator at home. We couldn't get enough fuel to keep the electricity going to treat one of the hottest zones in the world at the time, whereas here in the US we had stockpiles of supplies at all the major airports, all the major hospitals. To learn about the great differences in preparation and supplies, we didn't have enough supplies to at least give compassionate deaths to our patients. We literally had nothing. I went to sleep. I woke up when the sun came in that morning. And when I'm challenged by something that I don't know how to manage, when I don't know how I'm going to go back to work, I turn to poetry. I left my shift, and I picked up this Whitman book that my sister had sent with me. She said, read about Whitman, and I missed Virginia at the time. So I looked for a poem that mentioned Virginia, and I found a poem that said, as toilsome I wandered Virginia's woods. And I thought, oh, that sounds fancy. I'll read that and fall asleep and get ready for the next night shift. But right above the poem, another poem stuck out, and I want to read that right now, because this was my experience. A sight in the camp in the daybreak gray and dim. A sight in camp in the daybreak gray and dim, as from my tent I emerge, so early sleepless. As slow I walk in the cool, fresh air, the path near by the hospital tent. 3 forms I see on stretchers lying, brought out there, untended, lying. Over each, the blanket spread, ample brownish woolen blanket, gray and heavy blanket folding, covering all. Curious, I halt in silent stand. Then with light fingers, I from the face of the nearest, the first, just lift the blanket. Who are you, elderly man, so gaunt and grim, with well-grayed hair and flesh all sunken about the eyes? Who are you, my dear comrade? Then to the second I step, and who are you, my child and darling? Who are you, sweet boy with cheeks yet blooming? Then to the third, a face nor child nor old, very calm, as of beautiful yellow white ivory. Young man, I think I know you. I think this face is the face of the Christ himself, dead and divine, and brother of all, and here again he lies. Suffering is not unique. Whitman wrote about suffering he witnessed while working as a medic in the war. I worked with soldiers and veterans in the Ebola crisis who had served in other wars, many of whom said this was far worse than working in war because we couldn't see the bullets, we couldn't see the aggressor. We knew every day in just touching our patients we were exposed to Ebola. suffering persists. Today I want to talk about some tools that I've learned from the people that I've worked with and treated on how we can look at that suffering no matter what. No matter that we have nothing, because we will all face a time, if we've not already, when we literally have nothing, but there are tools that we do have. I like to put this map up when I talk about Ebola, just to remind people that Africa is a very large continent with 54 countries, even though the media said Ebola is in Africa. When I come back and I talk about this, people say, oh, what language do you speak? Do you speak African? The othering that took place during the Ebola epidemic, I would argue, cost lives. A landmass roughly the size of California and Oregon was where the heaviest caseload was, although the resource-rich world was stocking up supplies just in case one case got here, one case got there. By our own protection and defense, we cost lives. And while lives were being lost, I learned some of the most important lessons I've ever learned. I'm going to speak to you about a child named Mobinti. Mobinti was 8 years old. Mobinti came to us in the back of an ambulance with her 10-year-old brother. Both their parents had died of Ebola, and the local chief had found them alone in their home and called. There was a number. It was 117, just like 911. The chief called the number and said, we have 2 kids who I think are sick. They were put in an ambulance. They were driven hours away from home. And when they arrived to us, we sprayed down the doors. We opened the doors. Mobinti and her brother were both very sick. They had vomited. There was diarrhea in the ambulance. And when we saw a child that sick, our first goal was to get them hydrated. We thought it's very likely they would have Ebola, so let's start hydration. This is an image not of Mobinti. This was given to me by Partners in Health of the team members trying to start an IV on a writhing, angry, horribly afraid child. So we start treating the children. And Mobinti and her brother were great patients. We brought them into our suspect ward. We drew their blood. When their blood came back positive for Ebola, we immediately sent them to our confirmed ward so they could be surrounded by other Ebola patients and we could give them intensive care. This is what they saw every day. This is a photograph of our Ebola training run by the military. Ghosts, beasts, monsters is what we were. Dressed in white from head to toe, dressed in yellow from head to toe, sometimes dressed in green. The only thing that our patients could see were our eyes. The only thing. Inside of these suits, it got up to be about 130 degrees. When we finished doing our work and doffed our suits, which were covered by Ebola by the time we finished treating patients, we would sit and hydrate with about 6 or 7 liters of water and Gatorade every day, just so we could go back in and spend another couple hours wearing these suits. This is what Mobinti and her brother saw every day. As a peds nurse, it was my job to encourage her to eat, to drink, to not throw up, and to move around, because we found that patients that moved more were more likely to survive. Mobinti hated me. And as I treated her more and more, she got better and better, and her brother got progressively more ill. It got to the point where he couldn't move, but he was always telling her to eat and accept the drugs. She laid next to him on a cot, and they would hold hands. And we would come in and treat the two. And Mobinti would see the needles. I'd have to give her IM ceftriaxone. And she would see the needle, and she would start trying to get out of the way. And her brother, with all his strength, would hold her hand and look at her and say, sit still. And she did. When we brought food to the two of them, he refused to eat until she had already eaten half of her tray. The day that her brother died, we lost 3 other children. It was a horrible, horrible day. And I went in the evening shift. I wasn't there when he died. And I went in the evening shift, and I saw Mobinti, and she sat up in bed, and she stormed right to me and got up in my face and pulled out a children's book. And she grabbed my hand, and she took me right out the ETU and sat down and pointed at it and asked me to read this children's book to her. I had never seen such fire in this child or any of the patients that I had treated. It's as if when her brother died, he transferred the remaining living energy that he had into her, and she got better each day. She stayed outside of the ward every day, and as practitioners came by, she singled out certain practitioners and made us read the book to her and made us give her food. And she was able to go home a couple weeks later. So this is where I'm getting with this story. When Mobinti left, and we were able to take her out of the treatment unit, when we gave her new clothes, when we washed her down from head to toe, she went to the front of the unit and waited for a bus to pick her up to take her home. Often, we would go out front to meet the survivors, because that was the only time they didn't see us looking like this. That was the only time they didn't hear our voices rough. I mean, it sounded like Darth Vader. It was disgusting. It was grotesque. It was horrific. And so we go out to see the survivors. And I went out with a team, and we had a couple huggers in the team. We had some huggers in the group, even though we weren't supposed to touch and hug. And we had some people that were very callous until they saw a really sweet child, and then they totally melted. We all had different attitudes toward the survivors. We walked out, and Mobenti saw us, and she charged at me and gave me a hug that felt like it lasted 10 minutes. She saw one of the other pediatricians and went directly to him and did the exact same thing. And we had a couple other docs in the group who were big huggers, and they needed the hugs to refuel. And so some other docs were like, oh, Mobenti. And she just went right by them. Right by. They got nothing. And then me and the other provider were just like, yeah. But we realized in that moment, Mobenti, despite the fact we were completely covered head to toe, knew who we were. She knew our presence. And I think I would argue that's the first thing that as nurses, as physicians, as teachers, as providers, as humans, no matter where you are, so long as you're living, you have a presence. From the top of your head to the tip of your toes. And if you can live and work and express yourself in that way, no matter what the situation is, if you can enter the space with that presence, you've already got to step up in a completely dire situation. Mobenti was 8 years old, and she knew every inch of our bodies. She could understand that. Presence. We're here right now. We have these instruments. As an actor, I was always trained, use your instrument, know your instrument, play with your instrument. So I want to talk a little bit about our instruments. Is anyone familiar with the idea of sympathetic resonance or emotional resonance? Imagine you have an orchestra full of instruments, and there's no one sitting by the instruments. They're all just sitting there lined up, so you've got an image like this, but there are no people. If someone comes out on a violin, and you have to put a device on every string on all the instruments that measures movement, okay? So you've got this experiment set up. If someone walks into the space and takes a violin and plays an A string, is there an A string on a violin? Yeah, okay, great. So someone plays the A string on the violin. I know cellos, but not violin. All the other strings will begin to vibrate. Strings that match that registry will begin to vibrate, and you can measure that vibration. Sympathetic resonance, emotional resonance. Ron Epstein talks about that work in a recently published paper. What is your emotional resonance? When you look at a piece of art and you get the chills, what is that? When you read a poem and all of a sudden everything seems to fit, what is that? As a nurse walking into a patient's room who is scared to death, and they look at you and they relax, what is that? That's your presence. That's how you can resonate with other people. It's not easy to do. It's really hard to measure. But I want to give it a try. If everybody kind of sitting for a second, if you could just repeat after me. I love it. People start laughing right away. Laughter's so fascinating, isn't it? It just bubbles up, and people laugh for all sorts of reasons. We can't control it. Great. Gain about 80 pounds right now. Good. Feel it in your belly. Now in your chest. Feel that vibration in your chest. It feels good. It's okay to do it. It's okay. Now, the upper register, go, hey, 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 hey. Hey, 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 hey. Hey, hey, oh. Hey, oh. Oh, hey. How y'all feeling? We okay? Okay, good. We've got more to do. The next story takes place in Haiti, in rural Haiti. This is the only image of clowns you're going to see. If I need to blank the screen, just raise your hand. I'll blank the screen. I was working in Haiti in 2011, just after the earthquake that basically destroyed the country. And we were working with a group of children. We were asked as clowns to come perform for these kids and also do workshops with the children on acting and playing. And they wanted, the NGOs we worked with were interested in seeing if we could work with the kids to help them feel comfortable going back into their homes. Kids were still sleeping on the streets, in tents. There were tremendous aftershakes that lasted a year after the earthquake. And we wanted to sort of bring this out with the kids. So we developed a bunch of different activities and things like that, and we realized one important thing that was missing. As a patient, what happens to you when you go to a hospital? You go into the emergency room. What happens? Take your clothes off. What else happens? Thank you. Questions. Rather impersonal questions, and then really personal questions. What else happens? Touching. Turn off your cell phone. Stop looking at that. We literally take everything away from our patients when they come in. We physically strip them, we emotionally strip them, because we need to get to the diagnosis as rapidly as possible so we can move on to the next patient. When I was working with these kiddos in Haiti, and this was, I guess I had been a nurse at that point, I realized that these children had been stripped of many similar things. And one key factor is that they were stripped from their names. Those of you who are providers, how many times have you forgotten your patient's name and you just, mindlessly refer to them as asthmatic in room 75? Whether you mean to or not, we get so wrapped up in what's going on, we forget the names of our patients. So we did an activity with these kids, because we were playing with the kids. They liked playing, but they didn't like it when we actually did structured activities, and they were very tepid and very cold. And so I asked one of the children where the ocean is. Does anybody know where the ocean is? Like here in Virginia, which way is the ocean? East, which is, I need fingers, I'm bad with directions. I see some fingers, okay. we are, okay, I see the majority of fingers are going this way. And I see one finger that way, so let's go this way. So I asked the children to throw their names into the ocean. And the first response was, and I thought, well, maybe my Creole's bad, so I asked one of the youth leaders I was working with to translate, and he translated the exact same way, throw your name into the ocean. And we worked with the kids for about half an hour to the point where we wanted them to say their name and throw it all the way into the ocean. And it started with kids, not wanting to move very much. Oh, here's my name. And it ended with this, after about 20 minutes of a child, I'll be the child, saying their name to themselves first, Tim, looking at the ocean, and then throwing. Tim! Did you see it go into the ocean? Did you see it go over the ocean, maybe? So some of the kids started throwing their names over the ocean. It was a silly game. I've done it with some students. Students are often as awkward when we get going. But then after playing that game, we could not hold these kids back. They were proudly saying their names. They were sharing their names to other community members that walked by. They were playing with a sense of ferocity. These children who had lost everything, playing with a sense of ferocity as if they were the richest, wealthiest, most spoiled kids who have everything in the world. These kids were playing at this top level because they were able to share their names after hearing their names. You have your presence and you have your name. So long as you're living, you have your name. And I think part of the human condition is understanding where our names come from and what that means to build towards our presence. So that when we come into a room, when we care for patients, we can be seen as who we are, whether we have the supplies or not. I'd rather be treated by a human being who needs to run back and get a few supplies versus a machine who's got all the gear and just starts to cut. Know your presence, know your name. This third story takes us to the U.S. It's very fun to talk about adventures and people that I've met in other countries, but so much of that is happening here. This is a story about Brian. Brian was a 13-year-old child. He was diagnosed with neuroblastoma when he was at a relatively young age. I was working at the emergency department in a hospital on the Upper East Side. And Brian had basically been sick all of his life. And he was from Florida. His mom took him to the oncologist one day, and his oncologist basically said, there's really nothing else we can do for Brian. He's getting progressively sicker. We've tried everything. We can't get him on a study right now. Enjoy the last days, perhaps months, that you have with your child. And his mom, ferocious as a lion, would not take that as an answer. As a pediatric nurse, I've seen guns, I've been held up at knife point, I've been assaulted working as a nurse before, but I think my biggest fear is a mother who is not getting her way. because mothers will do anything, anything, anything to protect their children, and I so deeply admire that. I so deeply admire that. So she wouldn't take no for an answer. They had been seen once at Sloan Kettering Memorial Hospital up in New York, and they had some family in New Jersey. So mom said, okay, oncologist, nice knowing you. I'm going to take him up to New Jersey to visit family. Because the oncologist also said, don't travel with him. He's a little too sick, don't travel. And she said, he needs to see his family in New Jersey. I'm going to take him up there. Little did the oncologist know that she was actually going to take him directly to Memorial Sloan Kettering. Literally, once they got off the plane at LaGuardia, she got him in a cab, and they went to Memorial Sloan Kettering. Went to the front door, and they said, who are you? She gave the patient's name, and they said, you're not a patient of ours. She said, no, I was seen a long time ago. They said, we may have done a consult, but we didn't follow you, so we can't treat you. Ever creative, ever resourceful, mom said, then what will you do for me right now? And the physician, who I don't know, who I still need to thank, put their son in a wheelchair and rolled him literally across the street to the emergency room where I was working, in the pediatric emergency department. And when Brian arrived, Brian was gray. He was sitting up, he was awake, but he was gray and was in excruciating back pain. We saw him, he was septic. We brought him back to a room. I immediately started the workup. We got labs, we got cultures, we got fluids rolling, and all Brian wanted was pain med. I need the pain med, I need the pain med, I need the pain med. Communicated with the team, got some orders for morphine. I knew it wouldn't be enough. This kid's been on morphine for almost a decade. So I pulled some extra morphine knowing that I would just sit here and I would just keep pushing it. We'll get Brian comfortable. So we're working on Brian. We're calling the teams, alerting the PICU, alerting the oncology team. And I give a small dose of morphine, and Brian's eyes roll in the back of his head, and he lays back. And I step out, and his mom is with him, so I know if she needs anything, she'll holler. And she yelled, Tim, come in here. So I turn around, I go back in, and his eyes are kind of rolled back. And he kind of looked like patients that I've given morphine to before that just want a really good fix, right? You give them that morphine, they're delighted, and they're like, yeah. So that's what it kind of looked like to me, knowing that he really needed pain meds. Maybe he's just relaxing. And his mom said, he's never done this before. And that worried me. So I did a little sternal rub, and he opened his eyes. And I said, Brian, are you okay? And he looked at his mom, and he looked at me, and he said, I just need to know that I'm still here right now. And I said, what do you mean, Brian? He said, am I still in this room? And I said, yeah. You're right here. You're in the hospital room. We just turned off SpongeBob SquarePants because you thought that was like a dumb episode. This is what's going on. I just gave you some pain medicine. I've got some more if you need it. Do you need more pain medicine? How's your pain? And he looked at his mom and he said, can she get in bed with me? I said, okay, we can arrange that. From that moment forward, for the remaining 5 minutes of his life, all he asked for was having his mom at his side, in bed with him. Didn't complain of pain, had no complaints. As his oxygen saturation started to go down, he was in the mid-80s, we moved him into our resuscitation room, and we started getting nervous. Mom picked up on it. She was asking me, Tim, what's happening? What's going on? More team members are coming into the room, and then Brian sits up at one point, and he looks around, he says, can someone please tell me what's happening? I can't breathe. And he lays back on the stretcher. Within 30 seconds, we started doing compressions. We ran a code with Brian for about 2 hours. We had multiple teams come in the room. Those of you who have run codes before, been members of codes, you know the chaos that ensues when you're trying to desperately save a life. And I would say that's heightened based on my experience when you have a child whose life you're trying to save. We did everything we could. Working. We got Brian's dad on the phone in Florida. And for some reason, the phone was handed to me. And I think I know why. I'll get to it in a second. And I was speaking with him, and I was trying to explain what was going on. And I said, sir, do you have anything you need to say to your son? Because if you do, you need to say it right now. And his dad said, yeah. So in the midst of this code of accessing the central line, of running drips, hanging drips, doing compressions, I get down, kind of crouching down, and I hold this phone to Brian's ear for about 15 minutes while his dad says what he needs to say. I take the phone away, I give it back to his mom. His mom passes out. She's at the foot of the bed. We know that family presence in code situations, more and more the research tells us this, it's often appropriate. So we get mom some oxygen, we put her in a wheelchair. She's not leaving. The code ensues. And I realized that throughout the code, she's been calling my name. Tim, tell me what's going on. Tim, fix this. Tim, why is this happening? Tim, who is this? What is this? What's happening? All these questions directly to me. And after a while, I was not running the code. I started it. We had the PICU attending down there. We had our team. It was actually a relatively well-run code with a very clear hierarchy of leadership. But Mom had no idea, so she had to keep going back to me. Tim, tell me. Tim, tell me. Tim, tell me. We called the code. We turned off the monitors. We sat with Mom for a long time. We sat with the team as long as we could before we had to go back out and treat the rest of the patients in the ED. And after speaking with some teammates afterwards, I realized that the only name the mom remembered was mine. Now, I'm not going to go and say I was the only care provider who actually introduced myself. I don't think that was true. But as things got busier and more hectic, our own names sort of disappeared. I doubt very few of the providers actually knew Brian's real name or his mom's name. When all else fails, you have a name and your patients have a name. And when all is lost, his mom lost everything that day. She was able to hold on to my name and her son's name, who she wailed at the top of her lungs in our chapel, in our emergency room, and down the hall as she went home. Never lose that. Never lose sight of that idea that you have a name, that your patients have a name, and you can always go back on that. It's absolutely essential. So you have your presence. You have your name, you have your patient's name that builds the presence. And last but not least, far from least, I want to share a story that's been inspiring me for the last, 5 weeks now. I have a dear colleague with whom I worked in Sierra Leone, treating Ebola patients, who is now working at a hospital in Kabul, Afghanistan. At her hospital, she stays in a dorm directly across the street from the hospital. So when she wakes up in the morning to start her shift, there's a full security brigade that picks her up at her dorm and literally takes her across the street to the hospital. And at the end of the working day, the security brigade, these are armed vehicles, soldiers with big weapons, taking the staff back across the street because it is so dangerous there right now. A war that we started 16 years ago is picking up again and ravaging. She's a pediatric trauma nurse. They have very limited supplies. I would say they have more supplies than we had in Sierra Leone. They have very limited supplies. She's working with an NGO called Emergency. One thing that she has found that has worked wonders for her patients is this. Can everyone see what this is? Oh no! Let's get rid of that screen there. A rubber chicken. As I said, I'm a clown. And I spent some time with my friend before she left, and I gave her a chicken. I said, keep this in your pocket, and just carry it around with you. It's a little reminder that we love you, and we care about you, and we're thinking about you. So she started doing that and carried it around in her scrubs, and kids started grabbing it, playing with it. So now she's got one pocket full of alcohol wipes and one pocket of rubber chicken, so cleaning between patients, moving around. It got to the point where kids started stealing the chicken, hiding it. There was a fountain in the courtyard in the back, and she would find the chicken swimming sometimes through the courtyard. And then at one point it disappeared, and the kids were like, we don't have it. And she said, someone's lying to me. Someone's hiding this chicken. Turns out the surgery team stole the chicken, and we're doing procedures on the chicken, placing different bolts and screws and nuts and things like that. And then the chicken disappeared. We hope it went home with the child that was discharged after they survived. We're not sure. So she emailed me, and I sent her a box of 50 chickens. So she has many more chickens right now, and just sent a request for another box. So I think there are like 100 chickens there at this emergency hospital in Kabul. This is a photograph that she sent to me that I think sums everything up. This is an image of a child who is playing with his friends, found a landmine, who no longer has his arms, who has a mangled left leg and foot, but can do anything and everything with his right foot. And he spends his days pulling at, snapping, throwing this rubber chicken around the ward. It's not about rubber chickens. I wish it was. I'd have a lot more work that way. But ultimately, it's about creativity. And the creativity that you bring to your profession. The creativity that sometimes breaks the rules if it's not causing harm. I'm currently running a focus group with the Compassionate Care Initiative, and we've had some very interesting discussions about compassion and what compassion is, and how can you, if you see something happen, can you say, is that compassion? Can you sort of put it in a box? And we're not sure that you can. I kind of hope that you can't. But one thing that keeps arising in these focus groups is this absolute creativity. When there's nothing left, what do you still have? I'd love to leave you with that idea that we all have inherent creativity. Some people say, well, I'm not an artist, that's why I'm in med school. Whew. I'm not an artist, that's why I'm in nursing school. I think the best artists are nurses and physicians because they can manage this world of the abstract and the world of the concrete and bring the pieces together so that they can be present and connect with their patients and the patients' families and provide the highest level of quality care. So what is your creativity? Where do you find your creativity? And how does that creativity from your name build towards your presence that changes every day, which is great about it. We're always evolving, always changing. But how can you follow that and know that so that when you step into a patient's room, when you step into a situation that you can just not handle, you can just be there and you can provide the best care possible. I think of the words of Danielle Oliver, who spoke last week at Medical Center Rounds. And as I was putting this talk together, I kept going back to them. Very simply, she said, keep showing up and keep being present. To honor her words, I'd like to repeat that. Keep showing up and keep being present, and I would like to add a dose of creativity, and you'll be able to manage. Thank you all so much for coming today, for listening. I think we have some time for some questions. If anyone has any questions, comments, threats, warnings, dissertations, we have some mics floating around. Thank you. Thank you.
Thanks. As Tim indicated, we have a generous amount of time for some interaction with you. And I think, for one thing, if in this beautiful and moving presentation, if he set us all resonating sympathetically with him, but also with each other and with the kinds of perhaps remembered situations that we've been in where we have needed, you know, these kinds of basics that he has mentioned. You know, how can we work together in the next few minutes to think out loud about what it is we're doing, the work we're doing, the work we're called to do, the work that's hard to do? And what kinds of questions do you have for Tim that, you know, maybe kind of rudimentary, practical things like, where do I get a chicken? Or it may be, you know, a deeper, sort of more metaphysical question. How do I find time to discover my sense of presence? Things like that. So when we have a comment or a question, please do identify yourself, and then we'll have several minutes of conversation with this remarkable guy. So who'd like to start? And John, there's a question up there, all the way up at the top.
Thanks so much. I'm Justin Mutter from the Center for Biomedical Ethics and Humanities, and I'm a geriatrician here. And presence and naming is something that I think about a lot in my work with families and with older patients. And one thing that struck me, and I'm curious your thoughts on it, you mentioned breaking the rules, which I like that idea. But it's challenging, of course, to do that. And I want to contrast that vision with, well, let's just call it the technocratic vision of medicine, right? That we follow these procedures, we have set appointment times, we do all these things in a very algorithmic way. So how do we navigate that divide? Because it is a divide. And how do we do that meaningfully and break the rules appropriately?
Yeah, thanks, Justin. It's extra hard when you think about rule breaking in medical and nursing care because you could cost someone their life. one piece that I think of and when I speak with students is that in order to break the rules, you have to know the rules very, very well. And so the first step towards breaking the rules, if you think of Picasso and some of his very abstract pieces, if you look at his early work, he was a very, very fine technician. So train, know the rules, work with the rules, live in that world for a while, and then start to branch out. So I think that's one aspect. I think another is noticing when the rules are broken, and you might not even call it breaking the rules. I spoke with a nurse recently who talked about a patient who died, and the nurse wanted to do the patient's hair before the family came in, and fixed the patient's hair, and the family came in, and when the family reflected on their hospital experience, that's what they kept going back to. And they had been in the hospital for a really long time, but the fact that the nurse did the patient's hair. Now, that didn't cause harm, but I would argue that might be breaking of the rules, because as a nurse working in the ICU, that's the last thing I have time to do, because I have other patients to tend to, and other things were put off because this nurse needed to do the patient's hair. So I think also learning the rules really well, and then noticing the slight breaks and sort of growing off of those, and then celebrating that. When you have colleagues that break the rules, celebrate that. I worked with a colleague who would like to put Gatorade in urinals in the ER sometimes. Many of you probably know this colleague. And it worked sometimes, and patients loved it. And another time, this colleague got in a lot of trouble for it. So it's always a fine line. But I think as learners, especially, learn the rules first and foremost. And then I tell my learners, when we're in the classroom setting, this is the petri dish where I want all the experiments to fail. Because it's much safer that you fail in my classroom than you fail on the unit interacting with human beings that need your care. So let's try something new. Let's talk through new ideas, and let's see how that is bending or breaking the rules.
Just also to follow up on that, working with practitioners in that way and students, do you also envision working with leaders that way so that they know that people have had the kind of preparation where rule breaking may occur for all the right reasons?
Yeah, thanks, Marcia. I think in that form, it's how do you change the language around it so that leaders recognize this is what we're trying to do, this is what's going on, this is why it's important. And I think, we see a lot of change that happens from the bottom up. But I think sometimes when you change language, if you can change language from the top down, so everybody's talking about this idea of what is this sense of rule breaking? What is this sense of looking at things differently? If the leaders are talking about it, then I think there's much more permission with that. Narrative medicine is another great approach. When working with practitioners, providers who have been in the field for years and years and years, who, they can't remember when they were last in school. When you work in a narrative medicine setting where you're writing, you're sharing ideas, you're critiquing ideas, you can also frame that as a great place to fail. So maybe it's practicing failure. And for those of us that are making life-changing decisions, where can we fail? And let's fail as best we can in those places so we can go back and see how those experiments work out.
My name is Michael Swanberg. I'm at the School of Nursing. And I think I know that colleague who's putting the Gatorade in the urinal. But as director of the Contemplative Care Initiative, can you share some examples of nurses who are doing this creative work?
The creative work, sure.
Yeah, at the hospital.
Thank you, Michael. Yeah, and so, and to clarify, Compassionate Care Initiative, with the Compassionate Care Initiative, we have a group of ambassadors, clinical and faculty ambassadors that are working throughout the hospital and at the School of Nursing to help relieve stress, to help recognize and support people in what they're doing. One of the small rule breaks we have, we have a compassion cart that rolls through the hospital. It's led by a nurse by Carol, whose last name is slipping me my memory right now. Carol takes the cart to the hospital. It's full of snacks, it's full of goodies. I think occasionally it has bubbles. On units where you can't necessarily always have food, she finds ways to kind of smuggle it in. Clowns. Now, I know there's been some issues with the clowns at the hospital here, which I've been addressing with volunteer services, but you often see clowns in larger pediatric hospitals that are toilet papering rooms, having water fights in places where it's appropriate, lots of rule breaking going on there. We also, I guess you could consider rule breaking, we have people that will lead brief yoga practices during the middle of a shift, or brief mindfulness meditation practices. Hey, do you have 5 minutes? Come over here. So rule breaking in that we're breaking the norm, breaking the regular schedules, and in those breaks, we give a chance for our minds to change And we know that with changed minds, we think differently and can maybe provide better care.
Hi, my name is Lydia Whitman. I manage the patient and family library in the hospital, so I'm a librarian, but I've been in the hospital setting for about 15 years. I think what I want to share, though, is more from my experience as a care partner to a very sick person. In the hospital as a care partner, very different experience from being a staff person. And the nurse, there was some bad news that I had to get. And the nurse, instead of staying in her professional role, really connected with a personal story that was similar. You know, she said, when I got this bad news, and I don't know if that's rule breaking. I don't know what you learn in nursing school, how, it's probably impossible to say what that boundary, when it's appropriate. But I think it was really her humanity. She was connecting with me as a human being who's getting bad news. Mm-hmm. And that, I wish I remembered her name. I don't remember her name. But what I remember is that I felt really cared for. And that was compassionate to me because I was having trouble with this news. So, and that's here in a not third world, here in this setting, we have all these resources, but I was stripped down. I was feeling stripped down to nothing. And she was able to meet me there. So, I don't know. I guess it's not a question. I just want to say that was really powerful for me.
Yeah, thank you, Lenny. Thank you for sharing. And that's a beautiful story because in nursing training, we are trained to have boundaries. And I think you could argue that some rule breaks are when boundaries are broken and lines are crossed. And I've heard from some people, don't cry in front of the patients, and others, it's okay to cry in front of the patients. Some people say, don't bring your personal life to work, and others say, do, but do it so, in a sense, technically. I would think that maybe the nurse was almost being as much a technician as a human in that moment, knowing that this is how we can connect. So I'm going to give this to you. As nurses and physicians, we have to be careful, though, because if we give that out, then when we go home, we're completely empty. And that's part of the work we do with the Compassionate Care Initiative as well, is how do we recognize those lines and blur them? I think in this case, blurry lines are essential to good patient care. Don't quote me on that, I'll get in trouble. Or do.
Thanks for your talk, Tim, and teaching everyone how to avoid PowerPoint, among other important lessons. And the Dalai Lama also teaches know all the rules so you know which ones to break. And I want to thank the School of Nursing, not only for the Compassionate Care Initiative and for Tim, but for the first official therapy dog. And I'd like to issue an invitation to Behringer 5, to our center, to come and visit, okay?
Yeah. What's Kenny? Kenny's the therapy dog's name. Thanks for saying that, Denny. Yeah, we need more dogs. And that's rule bending for sure, I think. Yeah.
Trained hypoallergenic dog.
Yes, yeah, very well trained, yeah.
I think also, just to get back also to what was very early in your presentation, the comments about the importance of presence and naming. And one of the things it seems to me, and it connects with your experience as a care partner as well, is that sense of being known. When you're a patient, but also I think part of your presentation tells us it's important to be known when you're a caregiver as well, that there is that kind of recognition that's exchanged between two people who are kind of stripped down to just their essential humanity, when that is still present, and when, that kind of recognition can occur, and when, sometimes laughter can bubble up like those noises you got us to make.
Yeah.
And resonate with each other. It becomes pretty important. We did a writing exercise with some medical students, fourth-year medical students a couple of years ago, in which they were asked to write for 5 minutes about an instance when they were being cared for, when they were ill and being cared for. And then they read those accounts to each other. And it was interesting, out of, I think, the 11 students in the room, 10 were cared for by a parent, and 1 was cared for by a physician. There were 9 moms, 1 dad, and 1 anesthesiologist. But when we talked about this, it turned out the bottom line thing that mattered most to these students when they themselves were patients was the sense that the person caring for them knew them in a very deep and elemental way. And I hope that they carried that memory with them into their work with patients. Some of these illnesses were when they were like 4. One student had been sick with the flu earlier that year, and his dad had taken care of it. So these were long ago and recent, but it was important to kind of turn the tables.
Yeah. You know, that makes me think, in recognizing that you matter as a provider and your interconnectivity, I think about there's a Charles Bukowski book titled "What Matters Most is How Well You Walk Through the Fire." And as I was putting this piece together, I was thinking about that. But as we, in this discussion, I think what matters most is what makes you tingle. And when you tingle, know that and say, whoa, what is this connection? How is this happening? When you're in the room with a patient and family member and you get those tingles or those chills, that's a big indicator, and that's telling you something that I don't think we teach in the classroom. I don't think we can teach in the classroom. And if we can figure out how, we should start doing that.
Well, and how we could set up some of our educational settings so that tingling can happen.
Mm-hmm.
I mean, we're not going to be able to do this with lecture saying, okay, tingle now.
Yeah,
But,
the tingle
yeah.
lecture.
So thank you all for being
Thank
here
you.
with us today, and we hope we'll be sending you out with some new tools, new recognitions. Please join us next week. We have the first of 3 programs addressing aspects of the current opioid epidemic. Next week, we pair with Medical Grand Rounds for a program that continues on a conference that begins next Tuesday. We will have representatives from 2 First Nations of Canada, the Atakakoop community and the Big River community, plus Dr. Stuart Skinner from the University of Saskatchewan School of Medicine. They'll be talking about First Nations resilience. 2 communities take on an epidemic. This is also co-sponsored with Global Health. And what we'll be looking at are these 2 indigenous communities' grassroots response to a devastating epidemic, not only of opioid use, but also of HIV. So please join us next Wednesday, 12 o'clock, right here. Thank you. And thank you, Tim Cunningham.
I have 2 chickens if anybody wants a chicken. These are like high quality Amazon.